Okay, thank you very much. And a warm hello to everyone from New York. And I'm glad you are able to communicate in these awful times. And I hope it's getting better on your side. So, just to give you a little introduction of who I am, my name is Radhakrishnan. I'm a professor of medicine here at Columbia University in New York. And I also run a nephro-critical care service. So, right now, I'm on call. So, I've just taken a few minutes off to talk to you. And hopefully, I can share some of our experiences with COVID-19 as it pertains to the kidney. Okay, let me advance. Okay, I have no disclosures. And what we'll talk about in the next 30 minutes is why does COVID-19 cause organ injury? And this will include some of the basic pathomechanisms, including the so-called cytokine storm, which is a form of hyperinflammation, which can be seen not only with COVID, but other viruses like influenza. We'll talk about the role of renin-angiotensin system inhibition. So patients who come in on ACE inhibitors or ARBs, is it a good thing to keep going or to stop it? And the reason I'll tell you in a minute why this is important. Our kidney pathologists were instrumental in defining some of the early kidney syndromes associated with COVID-19. And I'll share some of the slides and then some of these clinical counterparts of these renal pathology findings. So I just took a snapshot a couple of weeks ago on the status of COVID-19 in the US. So this far, about the total population is about 350 million. So you can see that almost 30 million people have been infected, and that's an underestimate. It's probably more like double of that. It peaked really in January, although the early part of this pandemic in New York especially was in March, April. But the worst time we had was during the winter holidays, where there are almost 300,000 patients coming in on a given day, which is January. And fortunately, the numbers are coming down, but you can see that it's nowhere near gone. So you're definitely going to see this continuing probably into the next year. And what is also more distressing is that there have been 500,000 deaths. Again, it peaked a single day of 4,000 deaths in January 26th. And on March 7th, a few weeks ago, it was 600 patients around the country were dying. And even now, I'm just attending in the ICU. We've got one ICU full of patients on ventilators, and at least 1/3 of them are on continuous dialysis because of kidney injury. So what's behind the pathophysiology? Why does COVID-19 cause so much damage? We just examine the course of illness. You can see there's a stage 1, and patients may be asymptomatic, and these are the carriers that can transmit actually during this stage. And during this stage, your innate immune system gets activated, and your type 1 interferon gets upregulated. And that's a very important signature when you fight viruses, because you don't have antibodies at this time. So you're depending on what's called the innate system, which recognizes signatures, protein signatures of pathogens. And then interferon will activate certain cells in the immune system, and it will try to get the viral load down. But a lot of times it's not effective, and the viral load may come down, but not fully. And at this time, your adaptive immune system gets activated. So your IgM starts coming up and IgG starts coming up. And here we have the antibody response. And the second wave is certain signatures, protein signatures that causes widespread inflammation. And if this is not controlled, you go into stage 3. And this is where patients have ARDS, kidney failure, multi-organ failure, because there's an upregulation of a whole host of cytokines. You get activation of the coagulation system, and you also get complement activation. And this is the so-called hyperinflammatory stage where you get a cytokine storm syndrome. Patients are essentially at risk of dying in stage 3. You can stop the illness at stage 2 and you get a reversal of immune response and the viral load goes away, you will recover. So this is a schematic that one of our cardiology fellows actually put together.
I'm sorry to interrupt you, but could you talk a bit louder? It's like, yeah, thank you.
Can you hear me now?
Yeah, it's much better.
Okay, sorry about that. I'll hold the mic close to my mouth. Okay, so if you can hear me now, if you look at what happens with the COVID virus, so you see these spikes. So these spikes are very important in engaging to the ACE2 receptor right here. And once it does this ligand binding, the virus gets internalized into the cell. And then it is causing cytopathic effects, directly cytotoxic. But the other thing that's of concern, and I mentioned this in the beginning, is that when it binds to ACE2, you get a downregulation of ACE2, which allows unregulated angiotensin 2 ligation, because this is increased angiotensin 2. And angiotensin 2, as you know, is pro-inflammatory and it causes vasoconstriction and it causes damage to the vessels. So the idea is that if you have a ACE inhibitor and it prevents the ligation of the system, you may get unregulated A2 effects, causing potentially more damage. So what happens next is that the one important cell is the endothelial cell. And here you can see that because of direct entry into the cell, you get damage and you get inflammation. And all these things lead to widespread, not only inflammation, but also thrombosis. And this is the basis of organ injury. And then widespread release of cytokines will amplify this problem, and it leads to multi-organ failure and eventually death. And you can see every organ is involved, from the brain to the kidneys to the liver to the GI. You get thromboembolic manifestations. You may get myocarditis. You may get diabetes, and in the skin you get what we call petechiae and libido. And from our standpoint as a nephrologist, we see acute kidney injury, proteinuria, and leakage of red cells into the urine. So cytokine release syndrome is not unique to COVID. And you can see in patients, even with ARDS from any cause, they are inflamed. And this is one of the reasons why patients, despite being on a ventilator, can lead to propagation of organ injury and multi-organ failure. So you can see influenza is very commonly associated with EBV virus, certain malignancies, and there's a familial form of what we call hemophagocytic lymphohistiocytosis, HLH. But the important thing is viruses are a big reason why cytokine release happens, and it leads to the hyperinflammatory state. So coming to the kidney, we discussed about direct effects on the vascular endothelium, and viruses can certainly do that. But the other important part is that you have damage to the podocyte, which is an important cell in maintaining the glomerular basement membrane barrier. So every cell in the kidney may be either directly involved or more likely indirect effects because of either volume problems or organ crosstalk. We saw lungs causing damage to other organs, and things we do to our patients, like management of fluids is not correct, mechanical ventilation causing hypovolemia because of impaired venous return, and the use of nephrotoxic antibiotics. So it's not one reason, it's multiple reasons that causes acute kidney injury in patients with COVID-19. So coming to the question of whether RAS inhibition is good or is it bad. So if you look at ACE2, which is the receptor for the virus, you can see that the kidney certainly has ACE receptors. It's actually the most prevalent in the colon, but every organ has these ACE2 receptors. And remember, it's required for the virus to gain entry into the cell. So if you block ACE, you may actually cause increased expression of the ACE2 receptor, which might facilitate virus entry and progressively cause kidney damage or other organ damage. So remember, ACE2 is good. So if you have little ACE angiotensin 2, but more of the ACE2 receptor, you're actually, it's been shown to protect organs. But if you have the opposite, ACE2 down and angiotensin up, you can actually maintain organ injury. So the question is, do you want ACE2 down or ACE2 up? ACE2 down means you might block more viruses coming in, but on the other hand, you may prevent some of the organ protection effects. So let's look at clinical data. So these are patients who are hospitalized with severe COVID-19. And the question was, are they users or non-users? And you can see that when you look at people who are using ACE inhibitors or ARBs, there's really the risk of death actually is not high. Actually, it leans more towards, especially in one study, benefit in patients who are on ACE inhibitors versus those in whom it was stopped after admission. But the best data comes from this randomized study. It's called the Brace Corona study. It was done in Brazil, in South America, and they randomized patients to either stopping ACE or ARB for 30 days after admission or continuing it for 30 days. And the primary outcome was mortality and whether they can make it out. And you can see very clearly that there was absolutely no difference whether or not the patient stayed or stopped the ACE or ARB. So it really doesn't matter clinically. If the patient needs control of blood pressure, you can certainly continue it, but it doesn't seem to benefit. It doesn't seem to harm patients. Clearly, if they are in compromise in terms, so one should clearly stop it. If not, you can easily continue. So let's look at the kidney pathology in COVID-19. And this is our pathologist, Dominic Santoriello, and our fellow who's just graduated, Pascal Kairala. So they put together a series of patients that died of COVID-19 and what were the post-mortem findings. So these were 42 patients, and we looked at the clinical data and the medical record, and two pathologists looked at the slides to make sure that there was no mistake. And then the most important part was, can you actually demonstrate the virus in these autopsies? So you look at these patients, they were older as expected, they had a lot of comorbidities, and 94% had developed acute kidney injury, and of this 8 were receiving renal replacement therapy. And the most common finding was a really not bad looking kidney. So it is acute tubular necrosis, you can see right here, and it is not very severe. So it looks like mostly it was a hemodynamic problem. Some patients had vibrant thrombi, and I've shown you that the virus actually causes damage to the endothelial cells. So you may see microthrombi here. And a single patient had what we call collapsing FSGS. And I'll talk about this a few slides down the line. But more importantly, you cannot demonstrate that the virus actually was invading kidney tissues, either by in situ hybridization, which is very sensitive, and on electron microscopy, we could not demonstrate any virus particles. So acute tubular injury is the most common finding in patients who have died of COVID-19. How about patients who are biopsied for acute kidney failure? So the most common finding was this entity called collapsing glomeruli. You can also see other immune lesions, some forms of tubular damage, like we saw, tubular injury, and then kidney transplants. So most of them had unrelated findings. So it's a lot of things you can see on patients with COVID, not necessarily related to the virus, because we could never find the virus in any of these biopsies. So how about the clinical syndrome? We said AKI was the commonest. And you can see our earliest report, which was published in BMJ. We took 1,000 patients who were admitted with COVID-19 in the New York hospitals. And you can see in the hospitalized patients who were not in the ICU versus ICU, there's some differences. So the mortality was 14%. If you were not in an ICU, it was up to 43% in ICU patients, leading to about 20% overall mortality. So the biggest reason for ICU admission was ARDS, the vast majority, and you can see right here. But kidney injury was seen in 78% of patients in an ICU and about 16%. And of these 78, 35% actually needed some form of dialysis. So that's a very high incidence of AKI. And this is from our other hospital in the New York area. And the main reason why I want to show this to you is that there are some stages of AKI, and you can see that stage 1 mild to stage 3 severe was almost equally represented. But the most important finding is that the onset of kidney failure happened right where mechanical ventilation was started. So this again is a fact that you don't get one organ isolated involvement. Everything happens in one shot, which is basically because of widespread inflammatory syndromes occurring at the same time as a consequence of COVID-19. And you can see the outcome again. The death rate is quite high, 35%. But some patients were able to be discharged at this time. So I'm going to share some of our own experiences. So this is our nephrology consult service, right? We see approximately at the beginning, about 30% were COVID positive in March. And within 2 weeks, you can see right here that almost 90% were COVID positive, which is the biggest reason for calling the consult. This black line is the number of new consults each day. So we normally see somewhere about, I'm going to say about 20 to 25 patients. So right in the beginning, we started seeing 100 new patients each day. And it spiked up to 200 within a period of approximately 2 weeks. And this green line is the number of people on dialysis. You can see that it very rapidly went up. So our system was completely overwhelmed. We were short of people, nurses, dialysis machines, dialysis fluids, and we had to engage in a very complex method of finding resources to treat all these patients. But fortunately, because of collaboration and cooperation amongst all the hospitals, there are 7 hospitals in the system, no patient was left behind, and we managed to treat everyone without loss of life from a lack of resources. So if you look at this, I already showed you, I won't repeat it, but these are some of the things we did. So we engaged a university-wide response, which is published actually in our journal as a manual. And we had to resort to measures like making continuous renal replacement therapy fluid from dialysate fluid. So we have to improvise these machines so that we can actually produce this fluid in the situation that we had to use this. And one of our very clever attendings made dashboards in Excel spreadsheet to make sure that the resources were allotted appropriately. So all these were very important in helping us fight this resource-intensive problem of COVID-19 and acute kidney failure. So the good news is that, well, there's good news and bad news. So if you look at mortality, if you have sick patients, and by sick, we mean something called the SOFA score. So if you've got high SOFA score, which is a sign of critical illness, your mortality or survival is actually very low. But if you make, the news is not bad, because you may get 40% recovery. You can see right here, the patient, these are the patients who died, and the vast majority of patients who recovered were able to come off renal replacement therapy. Some specific syndromes to COVID, you can see rhabdomyolysis. So every patient with COVID-19 should get a CPK level, which can be quite high because of damage to muscles. There are certain ICUs that actually give intravenous vitamin C in patients who are in shock, who reduce some of the oxidative stress. Unfortunately, it can harm the kidney by causing oxidosis. You can see these crystals on a biopsy of a patient who went with kidney failure. This is the EM from micrograph of these crystals. And some of these patients may not recover because of the inflammation that crystalline oxalate causes. So the fortunate news is that despite the COVID-19 not going away, the incidence of acute kidney injury in blue is coming down. So there are still lots of patients admitted, but for whatever reason, you're not seeing that many patients with kidney failure. So a word on this entity called collapsing glomerulopathy. This is a form of acute nephrotic syndrome. And what you see here are these epithelial cells in the glomerulus causing, it leads to proliferation and causes a collapse of the entire glomerulus. And this is identical to what we see with HIV nephropathy. And again, it's not from the virus itself, but it's from the cytokine that causes damage to these podocyte cells. And it is seen almost exclusively in patients who are of African heritage because they have the genetic risk factor called apolipoprotein L1. And if they have a double hit on this gene, the risk of causing collapsing glomerulopathy is almost 60-fold in the setting of a viral infection like COVID or HIV. And you can see this is the story with ApoL1 alleles. I won't go into the details, but that's the strongest correlation. And we call this CoVAN because it's like HIV-associated nephropathy. It's COVID-associated nephropathy. Some other rare syndrome is thrombotic microangiopathy. Remember, COVID is irritating to endothelial cells. So you may get atypical HUS that can be triggered by COVID-19. And we've had multiple patients in our hospital with this syndrome. In fact, we also use eculizumab, which is almost reserved for atypical HUS, in a patient with COVID-19 with quite good results. Patient is able to come off dialysis. And it is not only the vessels and the glomerulus, but the proximal tubule can also be involved with COVID. And you can see that patients may have signs of Fanconi syndrome, like loss of phosphates, loss of uric acid, loss of sugar, and of course, acidosis. And you can see that, again, they think these are virus particles in the tubules, but unfortunately, when you look at this with more specific staining, like in situ hybridization, we cannot really see the virus. But it's clear that many patients may not be in advanced kidney failure, but they may be in a state where they lose phosphate and especially bicarbonate, causing acidosis and hypophosphatemia. And then because of large vessel damage, you can get kidney infarctions. So a patient with acute flank pain and hematuria, one should look at a CT scan with contrast. And you can see these areas of the kidney that do not light up with the contrast right there. And that is one of the other syndromes we see with COVID-19, large vessel thrombosis. And then finally, the cocktail of drugs we use for patients who are admitted with COVID-19 includes not only dexamethasone, but this antiviral drug called remdesivir. And the question was, is it safe if your kidneys are not working? And we have 2 studies right now. And despite the fact that it's not recommended, the idea is that if the potential benefit outweighs the risk, one should do it. And there was a study that reported that there were no direct side effects from using remdesivir in patients with both acute kidney injury or chronic kidney disease. So to conclude, the COVID-19 is associated with multiple renal syndromes. Acute kidney injury by far is the most commonest. You may see tubular dysfunction, Fanconi syndrome, and there's a unique form of COVID-19 in the kidney called COVID-19 associated nephropathy or collapsing glomerulopathy, exclusively seen in patients of African heritage. And it's unlikely that this is because of direct viral injury, but most likely it's from system-wide cytokine release and so-called organ crosstalk. We've had patients on dialysis and kidney transplant. I did not mention this, but if they experience COVID-19, their mortality is quite high, 30 to 40%. And once you get COVID in a hospital, it's very, very important to launch a multidisciplinary planning committee to make sure that no patient gets left behind because of shortage of either machines or personnel or disposable items like fluids. Thank you very much. And it's an honor to be among students. It's always my first love. And I'll be happy to take questions if there are any.
Hello, Professor. I would like to thank you for this presentation and ask you how common are immunocomplex, how common are autoimmune diseases or immunocomplex formation in post-COVID syndrome and disease of the kidney? Do you know for some case report?
Yeah, there are actually quite a few. So we've had patients even within our hospital come in with ANCA-vasculitis, with anti-GBM antibody disease. In fact, we have one patient admitted just now, I'm seeing today, with ANCA-vasculitis in the setting of COVID-19. We've had patients who have known IgA nephropathy come in with a flare. Just like flares can happen with a viral upper respiratory infections. We have not yet seen a lupus flare yet, but other diseases like minimal change disease can flare in the setting of COVID. So this all relates to the upregulation of the immune system with a massive release of cytokines. If you have a baseline immune dysregulation, there's a chance that these patients may come in with a big flare or come for the first time with a brand new immune-mediated kidney disease. That's a very good question.
Thank you for your answer. And I would like to ask you, in previously healthy patients who get COVID-19 disease and after that have to take immunosuppressant therapy, is it possible to be reactivation of SARS coronavirus 2 infection in kidney or primary interstitial nephritis or something like BC virus or JK virus?
Right. So I think the good news is that it's not the virus doesn't get incorporated as of yet. You're not aware. For most patients who clear the infection, we have actually had the study in our own clinic in transplant patients. The COVID-19 viral carriage could occur as late as 4 weeks in the absence of any symptom. But eventually, by 8 to 12 weeks, all patients were clear of virus in terms of nasopharyngeal carriage. And none of these patients had a relapse of COVID-19-like symptoms. Now, there's this other syndrome, which is called post-COVID syndrome, which is being investigated right now. It's not clear if it's from the virus or it's from the immune dysregulation that accompanies the virus. But many of these people actually feel better after the vaccination for the virus. So it just might mean that you have to reset the immune system, quote unquote, to get rid of that syndrome. So this far, there's not been any clear case of COVID reactivation from immune